Please confirm. So welcome everyone to the Predictor series for oral and maxillofacial surgery. So I guess we all are meeting after a long time, and today I'm here to take the Predictor series session for the subject of oral and maxillofacial surgery. Good evening, Devyanshi. So now exact what is going to be asked in the exams cannot be predicted, right? But based on last few years assessments, I have chosen a few questions. All right. And these questions are more important rather than the questions, the more important are the topics pertaining to these questions. Okay. So I hope you all did attempt the test. Okay. Now we'll come and have a look at each question. So today, I will be focusing on how to attempt your questions in the exam, how to pick and choose clues given in your questions that will lead you to your answer. Okay. Good evening, Shrishti. So let's start with our first question. We have quite a lot of things to discuss, so we'll do it quickly. Coming to question number 1, a patient presents to your OPD with complaints of pus discharge from nasal cavity and nasal regurgitation on intake of fluids. Gives history of dental extraction in the maxillary arch 3 to 4 months back. Upon examination, you find a large oroantral opening. How do you proceed? Okay, so here the important things are pus discharge from nasal cavity and nasal regurgitation of fluids. All right, and there is a history of dental extraction in the maxillary arch 3 to 4 months back. All right, so nasal regurgitation points out towards a communication between the maxillary sinus and the oral cavity, right? So, and if the extraction has taken place 3 to 4 months back, so it is no longer a oroantral communication, it will be a oroantral fistula. Okay. Now, this communication between this opening or this fistula between the maxillary sinus and the oral cavity has caused an infection which is causing pus discharge from the nasal cavity. Okay. Okay, test was not uploaded. All right. Okay, I'll get it uploaded. So now let's look at our options. Option A is pus culture, empirical therapy, antibiotics, and closure with acrylic plate. B, titanium mesh, closure with buccal fat pad and buccal flap. C, empirical antibiotics, surgical removal of sinus lining, closure with buccal fat pad and buccal flap. D is pus culture and empirical antibiotics, close with buccal and palatal flap. Okay. Now looking at the situation given in our question, pus discharge. Wherever there is a pus discharge, you will first do a pus culture sensitivity, always. From any wound, from any surgical site, anything, you will do a pus culture and sensitivity. Okay. Then, now pus culture sensitivity takes around 48 to 72 hours to be available. Okay. So till the time pus culture reports are available, you will give empirical antibiotics. Empirical antibiotics are nothing but a broad spectrum antibiotics. Okay. And since the sinus is infected, you will do removal of sinus lining and you will close this fistula. Since it's a long standing fistula, it may require 1 or 2 flaps depending on the size. So you will do a flap closure. Okay. These are your steps of treating this condition. Now coming to the options, none of these steps are together given in any one of the options. So let's one by one rule out. Pus culture, empirical therapy, antibiotics, and closure with acrylic plate. Pus culture is fine, empirical antibiotics are fine, but closure with acrylic plate is not going to lead to closure of the fistula. Okay. Option B is titanium mesh, closure with buccal fat pad and buccal flap. Here we are not addressing the infective nature of the condition, and we are not addressing the sinusitis. So this is also not the correct answer. C is empirical antibiotics, surgical removal of sinus lining, closure with buccal fat pad and buccal flap. So here everything is correct, but they have missed out on the most important at the first step, that is pus culture. So this is also incorrect. Alright. Option D says pus culture, empirical antibiotic therapy, close with buccal and palatal flap. This seems to be the most appropriate answer in this given condition. However, this option lacks treatment of sinusitis, that is removal of sinus lining. But since this is the most appropriate amongst all four, this is going to be the answer. Okay. So, clinical scenarios. What I now want to emphasize are clinical scenarios related to maxillary sinus can be asked in the exams. They have been asked over the past 1 or 2 years in your previous year's papers. Okay. Now, coming to question number 2. A polytrauma patient brought into the emergency on stretcher with a cervical collar in place. On examination, the patient is unresponsive to painful stimuli, verbal commands. What would be your first line of action? A. CT scan of the head and cervical spine. B. Tracheal intubation with cuffed tube. C. Oropharyngeal airway. And D. CT scan head, face, cervical spine, chest and abdomen. Now again, let's see what information is being provided in the question. We have to pick up clues from the question. Polytrauma patient. When it's a polytrauma patient, that means the patient is suspected to have facial bone fractures. The patient is suspected to have a head injury. The patient will have a suspected cervical spine injury. The patient can also have a lumbar or thoracic spine injury. The patient can have any long bone injuries, or either long bones of the legs, arms. The patient may have multiple fractures of the rib. So a polytrauma patient means multiple fractures present all throughout the body and multiple trauma inflicted injuries all throughout the body. Okay, is brought to the emergency on stretcher with a cervical collar in place. So there is a suspected cervical spine injury. Okay. On examination, this patient is unresponsive to painful stimuli. Unresponsive. Unresponsive. This is important. He is unresponsive to painful stimuli, to verbal commands. What would be your first line of action? So, his eye opening, there is no response. There is no response to verbal commands. And there is no motor response. So, GCS is weak. Okay. Now, GCS between 3 to 8 is a comatose patient. Comatose patient, and this patient requires definitive airway management. Okay. So now let's see the options one by one. A. CT scan, head and cervical spine. This is not the first line of management. This, once the patient is stabilized, yes, you have to do this. B. Tracheal intubation with cuffed tube. Yes, this can be done. C. Oropharyngeal airway. So even this is ruled out. I just now told you the patient will require definitive airway, and this is not a definitive airway, the oropharyngeal airway. Option D. CT scan, head, face, cervical spine, chest and abdomen. This has to be done, but later, after the patient patient's airway is secure. So the correct answer is tracheal intubation with cuffed tube. Okay. Now, in these patients, always cuffed tube because it prevents the dislodgement of the endotracheal tube. And second, initially we do not know for how long the patient's airway will need to be maintained. All right. So rather than using a non-cuffed tube, the better option is to use a cuffed tube. All right. Please keep this point in mind. So even if you have a non-cuffed tube in the options and there is cuffed tube in the options, you have to mark cuffed tube. I hope that is clear to all of you. Okay. Now, quickly, I will tell you what all intubations are used when. A quick revision. So, for maxillofacial surgeries, nasotracheal tube with cuff and throat pack. This I have explained in my classes also. So, for all maxillofacial surgeries, nasotracheal tube with cuff and a throat pack. Submental intubation, the indication is panfacial fractures. Retromolar intubation also is indicated in panfacial fractures. Your LMA or laryngeal mask airway is a rescue airway and helps till definitive airway is put to use. Now, where do you use orotracheal intubation or oral intubation? That is, if you're intubating the patient in an emergency, in the situation which is just mentioned in the previous question. So that is an emergency. You have to secure the airway fast. There is an emergency. So in that cases, nasal intubation is time taking. Also nasal intubation, since there would be suspected skull-based fractures, we do not go for a nasal intubation. So a orotracheal intubation in emergency situations always. When you have to give CPR to the patient, there is unconscious patient or there is a patient who is having apnea. All right. And in basilar skull fractures. Okay. Now, nasotracheal intubation for maxillofacial trauma or maxillofacial surgeries. But, however, if there is nasal bone fracture or fracture of cribriform plate, nasotracheal intubation, or anterior skull base fracture, nasotracheal intubation is contraindicated. Okay. And nasotracheal intubation can also be used for TMJ surgeries. Now, South Pole RA and oral RA, I will be taking up this again in the revision series along with all the visuals of these intubation methods. All right. So we will again revise this right now. Just quickly, important theoretical points. So South Pole RA or oral RA is used in case of nasal surgeries or skull or brain surgeries. North Pole RA or nasal RA is used in maxillofacial surgeries and TMJ surgeries. Very important, fiber optic intubation, where it is used where neck cannot be extended or mouth opening is compromised. So, difficult airway, oral submucous fibrosis, and TMJ ankylosis. So, in such cases where we will not be able to visualize the vocal cords, or where we won't be able, or in cases where we won't be able to achieve neck extension. Right? And please remember, cleft lip and palate, where we have nothing to do with the occlusion, that is oral intubation. Okay. Now, let's go to the next question. Question 3. In 4th degree nerve injury, which of the following structures are damaged? A. Endoneurium. B. Endoneurium and perineurium. C. Endoneurium, perineurium and epineurium. And D. Complete nerve transection. Right? So I'll just tell you the answer here. The answer is endoneurium and perineurium. So the next slide, you all can take a screenshot of this. This is a very nice table explaining regarding nerve injuries. All right. And if you go through this table, you won't have to remember much. So nerve injuries there are two classifications of nerve injuries. All right. One is as per the degree. All right. So that includes first degree, second degree, third degree, fourth degree, and fifth degree. All right. The second classification is Seddon's classification. All right. So in Seddon's classification, it is neuropraxia, axonotmesis, and neurotmesis. All right. And Seddon's neuropraxia is equivalent to first degree injury. Seddon's axonotmesis is equivalent to second degree injury, and Seddon's neurotmesis is equivalent to fifth degree. Right? So Seddon does not have a classification for the third and the fourth degree of nerve injuries. All right, please remember this. Okay. Now, what all we need to remember, I'll just underline that. You only need to remember that much. So first degree Seddon or Seddon's neuropraxia. All right. So this is transient ischemia. Just remember this much. Transient ischemia, and there is conduction block. And another important thing to remember is the recovery pattern. Recovery is complete and it takes few hours to weeks. Okay, and there is no treatment indicated. Fine. Second degree nerve injury or Seddon's axonotmesis. All right, there is axon and myelin interruption. Axon and myelin interruption. Endoneurium is intact, perineurium is intact, and epineurium is intact. So all the three layers of the nerve sheath are intact. Okay. Recovery is complete. However, it is slow. It may take a few weeks, and there is no treatment indicated. Okay. Now, third degree nerve injury. Okay. There is this injury involves the endoneurium. So in first and second degree, the nerve sheath structures are intact. In third degree, there is injury to the endoneurium. However, there is intact perineurium and epineurium. This is important. Okay. Now, recovery pattern is variable. It may be slow. It may take up to months. And nerve exploration may be considered. Okay. Now, coming to fourth degree nerve injury. So, the injury involves the endoneurium and the perineurium. So this is also a question point and this is important. So these two structures are damaged in the fourth degree nerve injury and there is no recovery that takes place. All right. Spontaneous recovery is not likely and you require microneurosurgery. So you need to go under a microscope, visualize the nerve and suture it with very fine micro sutures. Fifth degree nerve injury or Seddon's neurotmesis, there is complete transaction or continuity disruption of the nerve, that is your endoneurium, perineurium and epineurium, all three are injured. There is no recovery here possible and again you have to do microneurosurgery. So please take a screenshot of this table, just one look at this table and you will be thorough with your nerve injury patterns. Okay. Coming to question 4. For a patient undergoing third molar surgery, how will you manage post-operative edema? Which of the following regimen of steroids are to be administered? 8 mg Texona IV intraoperatively. B. 8 mg Texona IV post-operative. C. 8 mg Texona IV intraoperative. Continue 8 mg dexamethasone BD on day of surgery and continue for the next 2 days. D. 8 mg dexamethasone oral 1 day before surgery and 8 mg on the day of the surgery. So here your correct answer is option C. 8 mg IV intraoperative, continue 8 mg BD on day of surgery and continue for next 2 days. Now, quickly giving you the guidelines for steroid usage after extractions. Now, why are steroids used? Because they provide relief from swelling, trismus and pain. Alright, so when you are removing the bone, there is naturally bound to be a swelling. Alright, so and that swelling will in turn cause trismus. So to keep this swelling, trismus and pain minimal, we use steroids. Now we can use dexamethasone. Okay, so 4 to 8 mg IV intraoperative, followed by 4 to 8 mg orally BD on the day of surgery. So suppose if someone has undergone an extraction today, you will give IV during the extraction. You will ask the person to take 4 to 8 mg twice today, that is when the surgery has taken place, orally, and for the next 2 days. Okay. Methylprednisolone can also be given. So 125 milligram IV during the procedure, followed by 40 milligram thrice on the day of the surgery and 2 days after surgery. So please remember this, these are important. And another very important thing, patient on steroid therapy. So patient who is already taking steroids prior to your planned extraction. So on the day of the surgery, on the day before the surgery, that is day before your extraction, day of extraction, and day after the extraction, double the dose of steroid. So if the patient is, for example, taking 40 mg, let's say methylprednisolone or Visolone or whatever, so day before the surgery, on the day of the surgery, and day after surgery, you will double this. Okay, and from the second post-surgical day, you will return to the normal dose. So very important points, please keep them in mind. Okay, so I have a question from Saloni. If during flap raising maxillary root is lost, then most common location is between periosteum and bone or maxillary sinus. So it depends. Alright, it depends. Regarding there has to be an exact question with all the 4 options. Which, first of all, which tooth is being addressed and what are the options given. Alright, so if you can tell me the entire question, I'll be able to help you better. Coming to question 5, which of the following is not an indication of surgical exploration of the orbital floor? So diplopia, which does not resolve significantly during the first 10 days, a fracture with large herniation of tissues into the antrum, C, incarceration of tissues leading to globe retraction, and D, enophthalmos of 2M. So the correct answer here is enophthalmos of 2M. Okay. Now let's quickly go through the indications for surgical exploration of orbit. So the first one is persistent diplopia for 10 to 14 days due to muscle entrapment. So if the patient is having persistent diplopia due to muscle entrapment, large defect of or herniation of orbital contents into the maxillary sinus, oculocardiac reflex or entrapment of orbital tissues causing pain, nausea or restricted eye movements, and enophthalmos of more than 2 mm or cosmetically significant deformity. So anything enophthalmos of 2 or below 2 is not a surgical indication for orbital floor exploration. Coming to question 6, perforated disc of TMJ is seen as a sequelae in which of the following conditions? A, TMJ dislocation, B, anterior disc displacement with reduction, C, anterior disc displacement without reduction, and D, TMJ ankylosis. So the answer here is anterior disc displacement without reduction. Okay. Now we'll quickly, I have given this table previously also in my sessions, so I'll give this again. The basic difference between disc displacement with reduction and disc displacement without reduction. So in disc displacement with reduction, the very specific feature is click on opening, alright, and a click on closing, that is a reciprocal click. Okay, and after initial 10 mm of mouth opening, the there is deviation to the affected side or the involved side. Now, in disc displacement without reduction, there is trismus. There is significant trismus, which is important. And if the patient tries to open his or her mouth beyond a particular point, there would be pain and deviation to the affected side, and this can progress towards perforation of the tooth. So this is important. Okay. So rather than the questions, please try to focus on the topics that I'm telling you here via these questions, and try to be thorough with these topics. All right. And I'll assure you, you'll be able to attempt more than 80% of oral surgery questions. Okay. So coming to question 7, what does segmental mandibulectomy mean? A, block of mandible is removed without disrupting the lower border. B, part of mandible is removed which causes discontinuity of lower border. C, removing part of mandible while leaving a very thin inferior border. And D, none of the above. So the answer here is segmental mandibulectomy. That means a segment or part of mandible is removed. So what will happen? This will cause disruption of the lower border or inferior border of the mandible. So the correct answer is B. Part of mandible is removed, which causes discontinuity or disruption of the lower border. Okay, so these are two diagrams. So this is your segmental resection or segmental mandibulectomy. Okay, this is your marginal resection or marginal mandibulectomy. Here lower border is lost. Okay, here lower border is maintained. And to make sure that adequate strength is left behind, here this should be at least 1 to 1.5 centimeter. All right. So you should have sufficient remaining mandibular height so that there are no pathological fractures. Coming to question 8. A female patient having grossly carious tooth scheduled for extraction was administered LA multiple number of times to achieve adequate analgesia and anesthesia. However, she suddenly developed sweating and slurring of speech. How would you explain the reason behind this? A, this is normal effect of LA, will settle down soon. B, systemic circulating levels of LA have reached 4 to 7 milligram per ml. C, systemic circulating levels of LA have reached 4 to 7 microgram per ml. And D, systemic circulating levels of LA have reached more than 10 microgram per ml. Alright. So here I want you to please pay attention. Don't get confused between option B and C. Please pay attention to the units. One is 7 milligram per ml and the other one is 4 to 7 microgram per ml. So option C is the correct answer over here. Okay. In a hurry, please don't end up marking 4 to 7 milligram. Sorry. You have to mark. You have to take care of the unit that you're marking. Okay. Quickly, let's revise. LA toxicity has been asked many times in the last few years. Consistently, there has been at least one question on LA toxicity in your exams over the past few years. So let's have a quick revision. So various features, CNS features and LA levels. So from 0.05 to 4 microgram, there is an anticonvulsant action. So there is a therapeutic action. 4 to 7 microgram per ml, there is talkative, the patient is talkative, or there is slurring of speech, which is a stimulatory CNS feature. 7.5 to 10 microgram per ml, there is generalized tonic-clonic seizures, and more than 10 microgram per ml, there is severe CNS depression and collapse. Alright. Now, various CVS features and LA levels. So, from 1.5 to 5 microgram per ml, there is antiarrhythmic action, which is therapeutic. And 5 to 10 microgram per ml, there is CVS depression evident on a ECG. And more than 10 microgram per ml, there is severe CVS depression and collapse. Okay. Coming to question 9. What is the most common use of the instrument shown in the picture? A. Elevation and retraction of cervical flap. B. Retraction of cheek. C. Retraction of tongue. And D. Protection of airway. So, students, this instrument shown here is, please note down and also take a screenshot. This is Milner's cheek retract. So this is for retracting the cheek. Alright. Oh, sorry. Option D, retraction of the cheek, is the correct answer. So there are a few visual questions in this session where I have tried to show instruments which are not commonly seen. Okay. But they can be asked in the exam, which you may not be familiar with. So please make a note. Please take a screenshot of those instruments. All right. Okay. Coming to question 10. In oral and maxillofacial surgery, alveolar distraction osteogenesis is commonly indicated for A. Increasing the width of the mandibular arch for orthodontic purpose. B. Reconstructing alveolar ridge defects prior to implant placement. C. Correcting class 2 skeletal discrepancies. And D. Creating space for impacted canines. So we all know that alveolar distraction is used for increasing the alveolar height. I have told this in my class also. So the correct answer here is increasing or reconstructing the alveolar ridge defects prior to implant placement. Okay, so what does alveolar distraction do? It increases alveolar height, right? And rate of alveolar distraction is 0.5 mm to 0.7 mm to 1 mm per day, depending on the size of the segment you are distracting. Smaller the size, lesser the rate. Okay, and there are few prerequisites. So minimum height which is required or which should be available for alveolar distraction to be possible is 8 to 10 mm, and minimum width that should be available for distraction, alveolar distraction, is 5 mm. Please note this down, important points these are. Coming to question 11. What is the name of the instrument shown below and what is the use? I'll also tell you the name. The question here just asks the use of the instrument. A. Maxillary disimpaction. B. Nasal bone reduction. C. Maintenance of airway. And D. Extraction of teeth. So this instrument is, please note down and take a screenshot. Hayton William maxillary disimpaction process. Okay, Hayton Williams maxillary disimpaction process. So, as the name suggests, it is used for maxillary disimpaction. So, option A is the correct answer. Okay, now, so I have a few photographs over here. So there are two types of instruments which are used for maxillary disinfection. One is Rose maxillary disinfection forceps, and one is Hayton-Williams maxillary disinfection forceps. Okay. Now this one is Rose. Okay. This one is Rose. This is a paired instrument. Okay. And just look at the position on how it is getting inserted. So the smaller curve in the nasal cavity and the steeper or the larger curve in the oral cavity, because this space is to accommodate your maxillary incisors here. Okay. This is a paired instrument. So there are left and right sides to this. Okay. So this is how a Rose will look. Alright, there are two used in a pair. This is Hayton-Williams. So as you can see, this goes and engages the maxillary tuberosities. Okay. This picture here is clinical picture of Rose. The first one, the upper one. This is clinical picture of Hayton-Williams. Okay. Used for maxillary disimpaction. Right. Now, just take a screenshot of this table as well. So this is the basic difference between these two. Rose disimpaction forceps. It's a paired instrument. Like I told you, there is left and right side. The operator stands behind the patient while using Rose forceps, and its uses are maxillary disimpaction. Okay. Hayton-Williams is a single instrument. It is not paired. There is no site determination to it, and it is not necessary for the operators to stand behind while using a Hayton-Williams. And there are two uses of Hayton-Williams. One is maxillary disimpaction, and second is also to reduce a palatal split fracture if there is any midline palatal split or if there is any palatal fracture. Okay. Coming to question 12. A 36-year-old male patient got his OPD done. It revealed a radiolucent cystic lesion in relation to 4-5 and 4-6. He was taken up for surgery. However, during surgery it was found out there was no associated lining present within the cystic cavity. How would you further manage this patient? A. Enucleation followed by grafting. B. Resection with continuity defect and immediate reconstruction. C. Curettage or freshening of bony cavity followed by grafting. D. Enucleation, peripheral ostectomy and chemical cauterization. So there was no associated lining. That means there is no pathology. It's a pseudocyst. Alright. So this can be a traumatic bone cyst, hemorrhagic bone cyst, or a idiopathic bony cavity. Fine. Can be a traumatic bone cyst, hemorrhagic bone cyst, or an idiopathic bony cavity. So option A, enucleation followed by grafting. There is nothing to enucleate. Okay. B, resection with continuity defect and immediate reconstruction. Again, there is no pathology. Why would you do a resection? Resection is usually done for aggressive nature or for tumors which are aggressive in nature or for malignancies. Okay. So C, curettage or freshening of bony cavity followed by grafting. Yes. D, enucleation, peripheral ostectomy and chemical cauterization. Again, there is no pathology. Why would you do enucleation, peripheral ostectomy and chemical cauterization? So the best option is curettage or freshening of bony cavity. That is, you induce bleeding inside the bony cavity so that both factors fill the cavity, blood bleeding happens in the cavity and bone regeneration happens. And if the bony cavity is large, you can also place a bone graft so that bone formation takes place. Right. So another emphasis is on if you remember my chapter, treatment of specific cysts of the oral cavity. Please do revise that portion. This topic has been repeated over the past 2 to 3 years in the NEET exam. Okay. Now, coming to question 3. It says, identify the procedure shown in the image. A. Daughtry procedure. B. Discectomy. C. Mitic anchorage sutures. And D. Lateral pterygoid myopathy. Okay. Now, this is the image of mitic anchorage sutures. Okay. Now, we all know mitic anchorage sutures are used for treatment of chronic dislocation, alright, chronic meningeal dislocation. And this acts as a direct restraint of the condyle. Okay, now mitic anchorage sutures, please listen carefully. It can play two roles. Alright, one is you actually drill a anchorage point into the condyle. You drill a hole. Alright, you drill an anchorage point into the condyle. Put a screw over there. I'm telling you in very simple terms. You put a screw over there, and that screw can be, a suture from that screw can be either anchored to the disc so that the disc gets repositioned, alright, and the condyle and disc are fixed to each other and the condyle does not dislocate. Okay. Second technique of doing this is drill a screw into the condyle and you drill a screw into the zygomatic arch, tie a suture between these two so that there is controlled movement of the condyle and it does not dislocate beyond the articular limits. Right, so that is what mitic anchorage suture, that is how it is done, and it keeps the condyle from dislocating. Okay. Coming to question number 14, the instrument shown in the figure below is used for to cut the bone, to remove bone spicules, C to remove maxillary anterior root tips, and D to cut the intermaxillary fixation wires. So this is a bone ronger, right? This is a bone ronger. It is used to remove bony spicules. Okay. So bone ronger. The particular one shown in the picture above was a blue menthol bone ronger. Please, this was asked, I think, in NEET 22. Specifically, the name of the bone ronger was asked. Blue menthol rongeurs. Blue menthol ronger. Alright. So, you can go through the other parts on your own. The uses, I'll tell you. It is used to cut and shape bone by grasping and removing small bony fragments or irregularities or spicules, especially after multiple extractions. Okay. For precise trimming, contouring and removal of bone during alveoloplasty procedures, and to trim harvested bone. So suppose if you have taken, let's say for example, a anterior iliac crest bone graft, you have retrieved the anterior iliac crest graft, so that bone is now irregular or you want to give it a little contour, you can use the bone ronger to give contours to the harvested bone. Okay. And removal of dead necrotic bones, especially in cystectomy cases. So these are the uses and these are important. Please keep them in mind. Now, coming to the next question, question number 15. Parents of a 5-year-old male visits you in OPD. They haven't brought the child along. They give history of reduced mouth opening and facial asymmetry and sleepiness during daytime. They hand over you the CT scan films and image of one of the section is provided below. What would be your diagnosis and how would you plan for your treatment? Okay, so I will just zoom out. Okay. Here you see bony ankylosis, and here you see somewhat partial fibrous type of ankylosis. Okay, but this is significant. Okay, now the diagnosis is obviously TMJ ankylosis, right? Let's look at our options. TMJ ankylosis and total joint replacement, TMJ ankylosis and interpositional arthroplasty with temporalis flap, C. TMJ ankylosis interpositional arthroplasty with growth center transplantation, D. TMJ ankylosis interpositional arthroplasty with buccal fat pad along with growth center. So a 5-year-old boy, you have to restore the growth, and also you have to make sure there is no re-ankylosis. The best option would be TMJ ankylosis interpositional arthroplasty with buccal fat pad and growth center transplantation. So option C and D both are correct, but D is the best because if you remember my classes, buccal fat pad grafting is the best because it prevents heterotrophic bone formation and it prevents re-ankylosis. Okay. Now, next question is again related to the previous question. In order to prevent heterotrophic bone formation after osteoarthrectomy, which of the following should be used? A. Cartilage grafting, B. Fat grafting, C. Muscle grafting, and D. Gap arthroplasty. So the best answer here is, I just now told you, fat graft. Okay. Now you can go through this buccal fat pad slide, but the point that I want to emphasize on is prevents heterotrophic bone formation, that is bone formation within soft tissues. Okay. This is what buccal fat pad does. And apart from that, there are certain measures which can help in preventing heterotrophic bone formation, that is long-term NSAIDs, bisphosphonates, and radiation therapy. Okay, and this has no, buccal fat pad grafting has no disadvantages. And long-term NSAIDs, please remember indomethacin. Indomethacin is the choice of NSAIDs which prevents heterotrophic bone formation. Okay, now let's come to question number 17. What is the histological nature of bone produced in distraction osteogenesis? So this is a one-liner question, very straightforward. The answer here is intramembranous. Please remember this mnemonic, DICE. So DO, intramembranous, crack, that is fracture, endochondral. You please remember this, you will not get confused. Now coming to question number 18. Action of toxic doses of LA on CNS can be best described as depression of CNS followed by stimulation, stimulation of CNS only, stimulation of CNS followed by depression, and D, depression of CNS followed by depression. So we had just seen the table, and there I told you that stimulatory clinical features develop first followed by depression. So option C is the correct answer. Stimulation of CNS followed by depression. Again, emphasizing on LA toxicity. Okay. Coming to question 19. A 32-year-old male presents after RTA with facial flattening, bilateral periorbital edema, mobility of entire midface and epistaxis. In palpation, there is mobility at the frontozygomatic suture. CT shows fracture lines passing through zygomatic arches. orbit and nasal bridge. What is the most likely diagnosis? Mobility of entire midface. Okay. So here this is pointing out towards a lymphoid tract. This is the correct answer. Right? Quickly see the fracture line of a. Keep this image in mind. Fracture line of a lymphoid fracture starts from the frontozygomatic suture, involves the medial wall of the orbit, floor of the orbit, lateral wall of the orbit, and involves the zygomatic arches. Okay, so it is also known as the highest high level fracture because it is the highest of the lymphoid lines. Suprazygomatic fracture because it is above the zygomatico-maxillary buttress. Transverse fracture of the maxilla, and craniofacial disjunction, that means the entire maxilla is separated from the cranial base. Okay. Coming to question 20. According to Kaban's protocols, which of the following is not a component of TMJ ankylosis surgical management? A. Aggressive resection of ankylotic mass. B. Ipsilateral coronoidectomy. C. Interpositional graft placement. And D. Post-operative maxillomandibular fixation for 6 weeks. So Kaban actually emphasizes on early mobilization. So post-operative maxillomandibular fixation for 6 weeks is nowhere given in Kaban's protocols. So this is the correct answer. Next slide is Kaban's protocols of 2009. Please take a screenshot of this. Okay, so that you all know this has been told by me in one of the previous sessions also, but these Kaban's protocols are important. Please take a screenshot and revise them again before you go for your exams. Coming to question number 21, it says, identify the approach shown in the picture and also identify the instrument being used. A. Gillies temporal approach, Bristow's elevator. B. Keen's approach, Rose zygomatic elevator. C. Transparotid approach, Bristow's elevator. And D. Gillies temporal approach and Rose zygomatic elevator. So we all can see that here it is Gillies temporal approach, right? And this instrument that is being used here is Rose zygomatic elevator. So option D is the correct answer. I will just now tell you the difference between Bristow's elevator and Rose zygomatic elevator. Okay. So I have told you this many a times. So Gillies temporal approach is a closed approach. It is via the temporal area or temporal fossa, and Gillies incision is 45-degree angulation to the zygomatic arch, approx 2.5 centimeters above this or ear, and the incision is given in between the bifurcation of the superficial temporal artery, and the insertion of elevator is between temporalis muscle and temporal fascia. Right? Now, this is very important. Bristow's zygomatic elevator and Rose zygomatic elevator. Alright, so just quickly the differences. This has a single handle and this has 2 handles. Okay. Here in Bristow's zygomatic elevator this is a little dicey to use because here you are taking leverage on the bone. Okay. However, since Rose zygomatic elevator has 2 handles, this one goes between the muscle and the fascia, and this one remains outside. So you can engage this elevator from here, hold it from in between that hole provided, and lift the zygomatic arch. Alright. So this one reduces the leverage on the Rose zygomatic elevator because it has 2 handles. Okay. If you come to this image, this end goes to elevate the arch, and this handle you can apply the force from the handle given above, so it reduces the leverage on the skull bone. Question 22 says identify the instrument. A. Mallet, B. Jiggly saw, C. Nasal rasp, D. Bone gauge. So this is jiggly saw. And the uses are, it is a manual instrument. Alright. This may of flexible wire. This one, manual instrument used for osteotomies, or to cut the. These days we use electric saws to cut the bone. This was used priorly. However, at few centers, jiggly saw is still being used. Now, coming to question number 23. In a patient with multiple facial injuries, head is best stabilized by A. Board and binding, B. Hard cervical collar, C. Soft cervical collar, and D. Hand and manual stabilization. So, I have given you a sequence in the class as well. So, the best is purposefully build head immobilizers, followed by board and bindings, followed by rigid collar. Followed by rigid collar. So the correct answer here is board and bindings. Please remember this sequence on how to mark the correct answer, and last year also there was a question on this. Now coming to question number 24. A 20-year-old woman presents to the clinic with a 6-month history of pain over the TMJ and reduced mouth opening. On examination, tenderness of TMJ is seen. Radiographic image shows resorptive changes in the condyle. Identify the situation. A. Disc displacement with reduction. B. Idiopathic condylar resorption. C. Fractured condyle. And D. TMJ dislocation. So the correct answer here is idiopathic condylar resorption. I have taken up this very similar question in one of my previous sessions also. So we'll quickly go through idiopathic condylar resorption. Okay. So it is also known as progressive condylar resorption or condylosis. It is a condition where the condyle progressively resorbs or loses bone. Okay. It's a rare aggressive degenerative disease. Mostly affects young females in the ratio of 9:1. Alright. And the most important clinical feature here is class 2 malocclusion with open bite. Please remember this. It can be given in as one of the clinical feature in the questions. There is receding chin or disappearing chin appearance. This is also important. It is reported in young females, teen to adolescent, and it is also referred to as cheerleader syndrome. Important. And there is predilection towards female teenagers actively involved in sporting activities. That is why the name cheerleaders syndrome. On radiography, there is diminished volume of condyle and alteration of condylar contour. Okay. The treatment is orthodontics and orthognathic surgery. If this is not possible, then condylectomy and reconstruction with osteochondral graft or total joint replacement depending on the age of the patient. So if you need to preserve the growth center, you will do a osteochondral graft. Alright. Or if you want to do, if the growth is complete, you will do a total joint replacement. Coming to the last question for our session today. Question 25. During ankylosis release, a surgeon performs gap arthroplasty but does not place interpositional material. What is the most likely consequences? A. Immediate nerve injury. B. Hemorrhage. C. High risk of reankylosis. And D. Malocclusion. So we all know if you don't place a interpositional material, there is high risk of reankylosis. So this is a straightforward question. With that, we come to the end of today's session. I wish you all the very best. Okay. Now I want to give you all a few tips, not just for oral surgery, but for your entire exam. So there is a little less than 1 month left. Right now, just concentrate on two things. One, you have to concentrate on the most probable topics that we are telling you, and second, your own weak topics. All right. And now is the time to revise theory for only these things. You don't need to revise the entire theory. Now is the time to revise your previous year's questions. Try to attempt as many as questions possible. Try to solve your questions, because that is what is required at the day of the exam. All right. So I'm sure all of you have prepared well. Now it is the time to put all your heart and soul into revising what you all have done. All right. Don't try to pick up new things right now. Try to just revise, and revise. You all have prepared well, and I'm sure all of you are going to do well. You just have to concentrate. Now you have to concentrate and try to get a hold on how to solve your questions and how to arrive at the correct answer. All right. So if there are any doubts, anything that you want to ask me, please let me know so that we can wind up the session. Saloni, please let me know the complete question of your doubt. I will answer the question accordingly, because in this kind of a question, there is a when to mark maxillary sinus and when to mark between periosteum and bone. Are there any doubts that you all want to know? Anything that you all want to ask? So I think we can wind up this session. I'll see you all soon, again very soon, with our revision series. If there's anything you want to ask me, you can please ask before we wind up the session. Okay. So I'll wind up the session. All the best, dear students. Do well and stay focused. Thank you. Good night.